Bismillahirrahmanirrahim. Good day, everyone. Welcome to this comprehensive series, When Pregnancy and the Kidney Collide. My name is Dr. Mahmoud Sheikh. I'm a nephrology consultant and the World Kidney Academy educator. Throughout these lectures, we will walk through both the normal physiologic and anatomic changes that happen in the kidneys during pregnancy, and then move into the major pathologic conditions that every nephrologist and physician should recognize. We will cover practical approaches to preeclampsia, acute kidney injury, thrombotic microangiopathy, and acute fatty liver or pregnancy, dialysis during pregnancy, and kidney transplantation also during pregnancy, because this is a broad, very important topic. This will not be covered in a single session. Instead, it will be presented as a series of multiple lectures, with each lectures focusing of a specific area and depth. The goal is to make this topic practical, clinically relevant, and easy to apply in real-life patient care. So let's get started. In a normal pregnancy, kidney physiology changes quite dramatically because of volume expansion and systemic vasodilatation. Both the maternal circulation and the kidney adapt very early in pregnancy. Renal plasma flow may increase as much as 80%, and GFR typically rise by around 50%. These changes can be seen as early as 4 weeks into pregnancy. As a result of this hyperfiltration state, serum creatinine normally falls during pregnancy, and even a creatinine value that looks normal outside the pregnancy may actually be concerning in a pregnancy patient. Serum osmolality also decreased by around 10 degrees, with a slightly lower serum sodium set point compared with non-pregnant women. In addition, physiologic glucosuria and myoproteinuria can occur because of increased filtration and altered tubular handling. Mild urinary tract dilation is also common during pregnancy and is usually considered a normal physiologic finding. Overall, it's very important to remember that normal kidney values in pregnancy are different from normal kidney values outside the pregnancy. During pregnancy, there's a progressive dilation of renal pelvis, calyces, and ureters. This happens mainly because progesterone reduces smooth muscle tone and ureteric peristalsis, in addition to mechanical compression from the enlarging uterus. Ureteric dilatation is extremely common in pregnancy, occurring in up to 80% of women. It's usually more prominent on the right side because the uterus tends to rotate slightly to the right, and the right ureter is more easily compressed as it crosses the iliac vessels. In fact, the right ureter may be dilated up to 20 millimeters, while the left one is usually less dilated, maybe up to 10. One important challenge is distinguishing physiologic pregnancy-related hydronephrosis from a true obstructive pathology. Findings that may suggest obstructions include a dilated ureter below the pelvic brim, abnormal renal resistive indices, or absent ureteric jets on ultrasound, especially when the patient is supine. The dilated collecting system can hold additional 200 to 300 ml of urine, which promotes urine stasis. Because of this urinary stasis, pregnant women are at increased risk of bacteriuria and pyelonephritis and the other urinary tract infections. Although this IVU image here demonstrates bilateral hydronephrosis, ultrasound remains the first-line imaging modality during pregnancy, with MRI sometimes used if the diagnosis remains uncertain. Pregnancy is associated with major systemic and renal hemodynamic changes. Plasma volume increases progressively during pregnancy, reaching its peak around 32 to 34 weeks, with an increase approximately 1 to 1.5 liters. Although red blood cell mass also increases, plasma volume rises disproportionately more, which leads to physiologic anemia of pregnancy. Cardiac output increased by about 40 to 50% due to higher heart rate, increased stroke volume, and greater venous return. At the same time, systemic vasoresistance decreases significantly because of vasodilatory mediators such as progesterone, relaxin, and nitric oxide. As a result, blood pressure usually falls slightly during early pregnancy, not much high, maybe about 120 for systolic, and for diastolic around 70 to 80. These systemic changes lead to marked increase in renal perfusion and GFR. Effective renal plasma flow and GFR rise early in pregnancy, sometimes as early as 4 weeks of gestation. By the second trimester, GFR is often about 40 to 50% above pre-pregnancy levels. Because of this increase in filtration, serum creatinine falls during pregnancy. Creatinine levels that might appear normal in non-pregnant patients may actually be abnormal in pregnancy. In general, serum creatinine is above value above 0.87 milligram per deciliter should raise concern for underlying kidney disease or maybe AKI in a pregnant patient. The exact mechanism behind these increase in GFR during pregnancy is not completely understood. In general, GFR depends on the balance between hydraulic pressure in the glomerulus and the oncotic pressure within the glomerular capillaries and the UF coefficient, ultrafiltration coefficient. During pregnancies, plasma volume expands significantly, which lowers glomerular oncotic pressure and contributes to the increased in GFR value, even though this renal plasma flow rises substantially. Glomerular capillary pressure doesn't increase very much because both the efferent and efferent arterioles dilate in a relatively balanced way. Measuring true GFR during pregnancy is very difficult. Historically, the most accurate method have been inulin clearance and measured creatinine clearance. However, commonly used equations such as MADRD and CKD API tends to underestimate true GFR in pregnant women and are not considered reliable in this setting. Cystatin C is also not very helpful during pregnancy because its levels don't correlate well with actual GFR. For that reason, serum creatinine remains the most practical and clinically useful marker of kidney function during pregnancy follow-up. It's important to remember that normal creatinine values in pregnancy are lower than in non-pregnant adults, as we mentioned before. In general, serum creatinines above 0.87 milligram per deciliter should trigger evaluation and for possible AKI or CKD in such pregnancy. The upper limit is also slightly different by trimester, around 0.86 in the first one, 0.81 in second trimester, and 0.7 in the third trimester. This table highlights some of the most important laboratory changes that normally occur during pregnancy. Hemoglobin and hematocrit both decrease because plasma volume expands more than red blood cell mass, leading to the physiologic anemia of pregnancy. Serum sodium falls slightly, usually around 135 millimoles per liter, because pregnancy resets the osmotic threshold for thirst and vasopressin release. Serum creatinine also decreased significantly, often around 0.6 milligram per deciliter, because of the marked rise in GFR. Serum osmolality falls to around 270, which is lower than in non-pregnant adults. Blood urea nitrogen also decreased because of increased renal clearance. Serum albumin decreased due to hemodilution, and values around 30 grams per liter can still be considered normal in pregnancy. Pregnancy is also associated with mild chronic respiratory alkalosis. Because progesterone stimulates ventilation, arterial PCO2 decreases to around 126 millimeters of mercury. The kidneys compensate for this respiratory alkalosis by lowering serum bicarbonate, which is usually around 20 millimoles per liter during pregnancy. And blood pressure may decrease slightly during early and mid-pregnancy values to lower because of the lower systemic vasoresistance, and also it's often returned to closer to normal baseline near term. Early in pregnancy, systemic vasodilation activates the renin-angiotensin-aldosterone system, or RAS. Renin, angiotensin 2, and aldosterone levels all increase substantially during pregnancy. This helps expand plasma volume and maintain adequate uteroplacental perfusion. Interestingly, despite high levels of angiotensin 2 and blood pressure doesn't rise because pregnant women become less sensitive to its vasoconstrictive effects. Relaxin also plays an important role by enhancing nitric oxide signaling and promoting vasodilation. Serum osmolality decreases early in pregnancy, usually by about 10 degrees, which lowers the normal serum sodium level by slightly. Even though increased GFR and progesterone have promoted sodium loss, this is counterbalanced by aldosterone and angiotensin 2 increasing sodium reabsorption. Overall, pregnancy leads to net gain of total body sodium and water. Potassium levels usually remain normal despite elevated aldosterone. This is because progesterone has an anti-mineralocorticoid effects and reduced potassium excretion. Pregnancy is also associated with mild chronic respiratory alkalosis. Progesterone stimulates the respiratory center, increasing the minute ventilation, lowering arterial carbon dioxide levels. Uric acid levels typically falls early in pregnancy because of increased GFR and reduced tubular reabsorption, though these may return toward baseline later in gestation. Mild glycosuria can occur during pregnancy because of increased filtered glucose load and relatively reduced tubular reabsorption. Urinary calcium excretion also increases, but the risk of stones doesn't rise dramatically because pregnancy also increases urinary inhibitors of stone formation such as citrate and magnesium. Microscopic hematuria is actually quite common during pregnancy and may be found in about 20% of women. In many cases, it's discovered incidentally because pregnancy is often the first time young women undergo repeated urine testing. Isolated microscopic hematuria, especially without proteinuria or impaired kidney function, usually doesn't affect pregnancy outcomes. Most women with isolated microscopic hematuria have a normal gestational age at delivery and normal birth weight and no increase in risk of preeclampsia. Clinically significant microscopic hematuria is generally defined as 3 or more red blood cells per high power field in at least 2 properly collected urine samples. In many women, the hematuria resolves after delivery. However, if hematuria persists postpartum, especially with dysmorphic red blood cells, proteinuria, hypertension, or elevated creatinine, further investigation is needed. The first step is in the evaluation is usually urine culture to exclude any urinary tract infection. The blood pressure, serum creatinine, and proteinuria all at normal range. Extensive investigations can often be postponed until a few months after delivery. Persistent dysmorphic and blood cells changes. The persistent after pregnancy may suggest the underlying glomerular disease, such as thin basement membrane disease or IgA nephropathy or lupus nephritis. Visible hematuria during pregnancy is less common and may result from hemorrhagic cystitis, vaginal bleeding, kidney stones, or renal vein thrombosis, or arteriovenous malformations, or even rarely kidney or bladder tumors. Treatment depends on the underlying cause. In women with a stable kidney function, normal blood pressure, minimal proteinuria, no specific treatment may be needed during pregnancy. Lastly, it's very important to remember that ACE inhibitors or RBS are contraindicated during pregnancy, especially in the second and third trimesters. Proteinuria is normally increased during pregnancy because of hyperfiltration, increased glomerular permeability, and reduced tubular protein reabsorption. Outside pregnancy, the normal upper limit for protein excretion is about 150 milligrams per day. During pregnancy, however, protein excretion may be up to 300 milligram and can still be considered physiologic. Proteinuria may be even higher in twin pregnancies and can be persist for some time after delivery. In routine practice, dipstick urine analysis is often used first, but is not very reliable. A negative dipstick is useful for excluding significant proteinuria, while readings of 3 plus or more are more likely to reflect clinically important proteinuria. Intermediate dipstick readings can be misleading and have high false positive rates. For that reason, spot urine protein to creatinine ratio or albumin to creatinine ratio is generally preferred over 24-hour urine collection. Significant proteinuria in pregnancy is usually defined as urine protein to creatinine ratio greater than 30 milligrams per millimole or about 0.3 milligrams per milligram. Gestational proteinuria refers to new isolated proteinuria without hypertension or any other features of preeclampsia. The diagnosis is often made retrospectively after delivery. In the absence of chronic kidney disease or isolated gestational proteinuria, is not usually associated with major adverse outcomes, though close follow-ups for preeclampsia is very important. Nephrotic syndrome in pregnancy is much more serious and is associated with increased risk of preeclampsia, acute kidney injury, infection, preterm delivery, and fetal loss. In women with very heavy proteinuria and low serum albumin, thromboprophylaxis with low molecular weight heparin may be also needed. Urinary tract infection is very common during pregnancy because urinary stasis, ureteric dilatation, and changes in bladder function all increase the risk of bacterial growth. Asymptomatic bacteriuria affects roughly 2 to 10% of pregnant women. If asymptomatic bacteriuria is left untreated, up to 30% of women may go to develop pyelonephritis. Screening with urine culture at least one during pregnancy is recommended for all pregnant women. Asymptomatic bacteriuria is defined as more than 100,000 organisms per millimeters in a patient without urinary symptoms. Common first-line treatment includes amoxicillin and cephalexin for about 7 days, followed by repeat urine culture to confirm eradication. Cystitis present with lower urinary symptoms such as dysuria, frequency, urgency, and suprapubic discomfort. Significantly, bacteriuria and symptomatic women may be present even at lower colony counts. Cystitis is generally treated similar to asymptomatic bacteriuria with a follow-up urine culture after treatment. Pyelonephritis is much more serious and usually presents with fever, flank pain, nausea, vomiting, systemic symptoms. Women with pyelonephritis often requires hospital admissions, IV antibiotics, and close monitoring. In some cases, suppressive antibiotic therapy is continued for the rest of pregnancy after an episode of pyelonephritis. E. coli is by far the most common organism responsible for the majority of infections. Other common organisms, including Klebsiella, Proteus, Enterococcus, Staphylococcus subrotificus, and occasionally Pseudomonas. Pregnancy creates several conditions that could theoretically favor kidney stone formations, including urinary stasis, hypercalciuria, increased uric acid excretion. However, the overall incidence of kidney stones during pregnancy is actually similar to that in non-pregnant women. Most stones in pregnancy are calcium-based stones. Interestingly, calcium phosphate stones are more common during pregnancy, whereas calcium oxalate stones are more common outside the pregnancies. The reason stone risk does increase dramatically is that pregnancy also increases urinary inhibitors of stone formations, including citrate, magnesium, and levocalcium. Symptomatic stones usually present during their second and third trimester. Patient often presents with acute flank pain radiating to the groin, lower abdomen, often accompanied by hematuria. Kidney stones during pregnancy are important because they can increase the risk of pyelonephritis, preterm labor, hypertensive disorders, gestational diabetes, and cesarean delivery. Ultrasound is the first-line imaging test during pregnancy. However, ultrasound may not always clearly distinguish physiologic hydronephrosis from true obstruction. If the diagnosis remains uncertain, myurography or limited IVU can sometimes be considered. Fortunately, most stones pass continuously during pregnancy, so initial management is usually conservative with hydration, pain control, and observation. Of note, lithotripsy is contraindicated during pregnancy. Thank you for so much for your watching. I hope everything was simplified and easy to follow. See you all in part 2 and stay tuned. Assalamu alaikum wa rahmatullahi wa barakatuh.